Colin Boyle. He's the Deputy Director of Global Health Sciences after many years as a managing partner at the Boston Consulting Group. I could go on, but in the spirit of brief introductions, I will leave it at that. Colin, thank you.
Thanks. So thanks, everyone. We have a wonderful panel, 4 great speakers, and we'll want to get to them into the Q&A as quickly as possible, recognizing that we're the last group before lunch, and that's always a precarious position to occupy. But let me just say a word or two about why implementation science is so critical in an economics forum like this. In many ways, implementation science I see as the next frontier of global health economics. Finding ways to improve performance of health systems and implement better is going to be something that's critical for researchers, for practitioners, and others in the field. So just a framework that we all know very well. Anyone who's received funding from any philanthropy or other group will know that philanthropists and funders are interested in seeing how their investment translates into impact, and they often require organizations to report using a simple framework, impact framework, inputs all the way through, and they want to know what happens to their money. And so the general rule of thumb is you ask, well, we'll give you money, and then with that money, you engage in activities, vaccination program, we give you money and syringes, you do a vaccination campaign, you produce a set of outputs. The outputs are vaccinated kids, and then based on the efficacy of the vaccine, you get outcomes, protection from disease, and over time, that leads to longer-term health impact. Sort of very generic model, and it applies to lots and lots of different types of interventions. It applies to, very effectively, to health, to environmental programs, to any number of other policies. Simple framework. Health economics has played a really critical role, though, in shaping how this is used in the global health context. We've seen people use health economic analysis on the front end to increase the number of inputs into the space. You can't read a Lancet article without stumbling across an investment case. For more resources, X $1 million more or $1 billion more will save Y million lives. It's everywhere. We just heard Dean Jameson and Steph talk through one of the premier examples of priority setting to optimize activities so that we know we're better off spending money on primary health care for children rather than tertiary care hospitals in low-income settings. We can prioritize. We've also seen health economics be effective in the efficacy space, translating outputs to outcomes. So what is it worth to get a higher performing vaccine, greater efficacy in a drug? Is it worth it? Is it worth including in formularies and policy guidelines? What's interesting is that 2 spaces have been relatively less well trod on. The translation of activities into outputs and going from outcomes to larger scale impact. And that's a place where we know there's a lot of loss. We know that even though on paper and in someone's studies, activities led to certain outputs, in practice, sometimes the doctors don't show up for work. Sometimes there are stockouts. There's enormous variation across health centers in performance. And finding ways to improve the outputs and get the impact through better effectiveness and scale up is really critical. So with that, we're going to have a wonderful panel of 4 speakers who do this work, who actually are leading the field in implementation science. I'm very honored to start with Margaret Handley. Margaret's going to come up and talk about her experience with cookstoves. Margaret's an epidemiologist in the Department of Epidemiology and Biostatistics here, and part of the Center for Vulnerable Populations. Her focus is on bridging the fields of primary care, public health, and health communication. And importantly, she directs the UCSF training program in implementation science. Her interests are diverse and broad, but right now she's going to share some of the work she's been doing in the area of cookstoves. So with that, I'd invite Margaret.
All right, good morning. Thank you very much for that nice setup for where we are focusing our implementation science efforts. I'm going to tell you a little bit about an implementation science approach to developing a behavioral intervention to increase the uptake of cookstoves in rural Guatemala. So the scope of the problem, I think it's pretty well known that household air pollution is a leading cause of death, and that's globally, particularly in countries where there's a large proportion of burned use of materials for cooking. It's the 10th leading contributor to disability-adjusted life years, which we were talking about earlier. The stove solution has been something that has been incredibly great with technology to advance the ability to have clean cook stoves in low cost and being implemented in many settings. However, the idea that the technology alone can get to full adoption has been unfortunately not sustained. So years of studies show that efficient clean burning stoves are inconsistently used when broader environmental factors and family level dynamics are not brought into the mix of developing interventions. So this gets to like what are the activities that help you implement so that you can really have sustained adoption. And then plus, in this particular case, there's the added problem of de-implementing the use of wood stoves. So it's not only that people need to start using cleaner cook stoves in their daily preparation of foods, but they need to stop using wood in order to really reduce household air pollution. So using an implementation science approach, I partnered with Lisa Thompson, who was here at UCSF a few years ago and now is at Emory, and her colleagues in Guatemala to continue on some work that they had started early on in cookstove work, which was also with people at the School of Public Health at UC Berkeley and others like Kirk Smith. So they've been doing a series of trials in rural Guatemala for years. And this project came in at the NACER study level, which was 2014 to 2017, which was adding a behavioral intervention to their cookstove implementation. So the specific aims in this project were to conduct a pilot study of this gas stove intervention that really brought a behavioral lens to what they could do in the household. And this was something that they wanted to use an implementation science approach. So this really was about how to change the communication they already were doing around cookstove use when they were at the household level. And then to look at the feasibility and acceptability of that added behavioral intervention to what they were already doing in the homes with the cookstoves, and then to also assess the outcomes that they looked at for household air pollution. So the intervention included liquid petroleum gas stoves, plus group classes for pregnant and postpartum women, which was the target group for this particular study, as well as home visits, which included visits with people who could do repairs and things like that. Several components to this intervention. So I'm going to just take a quick lens at implementation science, thinking around intervention development using theory-informed approaches. So I know you can't probably read all the stuff in the middle there, but it's not as relevant as the idea that sequencing, as we do when we think of preclinical trials to randomized clinical trial development, we also need to think about when you're at the early stage of developing a behavioral intervention and trying to make your maybe technology-based intervention fit in a particular setting for increasing adoption, you're really at this kind of early stage of thinking about theory. What are the ways that you can use existing evidence-based approaches that are theoretically based to understand the problem and then to think about how to match that back to the solutions that you might develop for those particular problems. So just as we do that with preclinical thinking, when the early stages of theory, you're really trying to understand a problem and then map that back to intervention components that relate to what you've identified. So I'm going to talk just briefly about this COMBI model, which is the capability, opportunity, and motivation model. There's books and websites about it, millions of articles written about it, so please look them up because it takes a long time to talk about it in great depth, so I'm just going to give you a snapshot. But basically, if you think about somebody doing a synthesis of all the behavior change theories and intervention development theoretical approaches and putting them all in a synthesis, this is a model that summarizes. So if you think about barriers to intervention development at the behavioral level, there can be capability barriers like skills. So this can be psychological or physical barriers that you might have to a skill that is required to do a behavior. You can have motivational barriers that might relate to things at the psychological level that are conscious as well as things that are not so conscious. And then you can have things that are in the opportunity space, and this is like basically everything else. So this is like the structural environment you live in, the family dynamics and social environment around you, as well as things like economic resources, and in cases like the wood stove use, access to services you might need for developing the gas stove competencies. So just looking at how this is operationalized, there are a lot of domains, and domains have a lot of questions that you could be asking in your environment. So you can do assessments. So you can do these through in-depth interviews or other formats, but essentially these are the kinds of questions. And in a lot of cases, the physical capability is not relevant to the skill, but in this case, it really is. So in this case, can women light the stove? Can they use a match to do it? Can women connect the tank to the stove? Like all these things that have to do with actually touching the stove in the household and using it are really important to think about here. At the sort of psychological level of thinking about what are the capabilities people need to have, some of the things that we focused on were, do women understand the health benefits of avoiding the wood? So these are like typical knowledge kinds of measures. And then things that are a little bit more complex, like are there situations where it might be really difficult to not use the wood stove? What are the enablers and what are the kind of behavioral skills you have maybe for action planning or anticipating? So these are things that come out of a lot of common psychological theories that relate to capability. In the opportunity space, you might have questions like what things in the surrounding environment are really getting in the way or might be leveraged to enable this to happen, this behavior to be more easy to do. And then in the social environment, what are the opinions of others? And in this case, at the household level, this was the most critical part, I think, in developing the intervention, is really understanding the social environment. So some of the questions we had here are like, how does the family procure gas refills? How do they have the resources? Do they have to use money? Can they call the repair person? Do they have a phone to do that? All these things that are really kind of practical barriers. There's a format for operationalizing to make sure you understand how much they're contributing to the behaviors that you want to understand more and then intervene towards. And then at the social level, do women think that other women similar to them are starting to use these stoves? So this was a really important component. It took a while to really understand the social dynamics in the group, because a lot of times the assumption is that bringing in technology gives you some status in a community. But in this case, women felt that if they were bringing in something new into the home, that they were showing off, and showing off is something that creates envy, and envy is bad in the dynamics of their peer group, especially for young women with children. So this was something that became really critical to our intervention. So motivation as well, these are the kinds of things like how much you want to do something, how much you value it. Those are things that are pretty typically understood for this. But a lot of other things related to motivation are more complex, and this is one of the areas that I think people brush aside, and intervention development needs to be really sort of delved in deeply for. So in this case, we have things here, are there good reasons to use the gas stove over the wood stove? What are those reasons? And really exploring those at the family level. Do women think using the stove had other impacts in their home, good or bad? So really kind of working through more of a thought process around this. And then, one other thing on that is that at the automatic level, these are kind of the things that are like emotions that we have, both positive and negative. So in this case, we found that there was a lot of non-motivation towards using the cook stoves because there was fear around them blowing up. And so people had a lot of fear that was important. So some of the findings we had for this when we did the sort of qualitative assessments and field visits that really helped us understand sort of with our list of attributes we wanted to link back to the behaviors of adopting the gas stoves and de-adopting the wood stoves was that men had a really critical role in this family decision making, even though women were the ones who typically thought of themselves in charge of all the cooking and all the food stuff. So the decisions around the gas stove were really different than other decisions around cooking, and it really related a lot to who was going to make the decisions to purchase the gas tanks, how would those be refilled, all the logistical things like that that have to do with costs, that have to do with who engages in the service sector of calling a repair person, even though they were offered free through the study and gas tanks were offered free through the study. The logistics of that engagement was really important for men to be involved in. And then the whole family needed to be targeted as well, because there was a lot of elders in the household who had a lot of opinions about how things were cooked. So this would be mothers-in-laws in particular, who women often were like trying to please in the home because they lived with them, and they didn't feel that they could necessarily make some of the cooking decisions unilaterally. And then this idea that I was referring to of women feeling that their social groups are really important, and so not to sort of create a disruption in the social group to be seen as showing off. So examples show just some things that we focus on, just picking a few here, but really emphasizing how to do safe gas use. So this is really in the capability space. So women would say things like, the news tells us about gas explosions, so there is fear in the community, but if we get trained, then we're not afraid anymore. What we saw in the home visits was that people just put like a little, cloth over the tank, and that was supposed to like deal with the leaking, and that wasn't very effective, but it also meant they kind of just said, okay, it might be leaking, I'm just not going to touch that thing at all. And so we developed some calendars. They had calendars about when their visits were going to happen that were linked to their prenatal care that talked and sort of imaged out here how to use the valves to turn things off, and they were trained in that. So these are the kinds of things that we focused on in capability in our home visits. And then this one that was really addressing the opportunity is more focused on this issue of comfort foods and things that were really traditionally valued in the home, like beans. And beans were being told to women by elders in the family that they didn't taste as good if they weren't cooked on the wood stove. And so women didn't want to do that. And there was also the issue that it took a long time to cook beans, and so they were using up a lot of gas. So this was an issue where they, in the intervention phase, started to do blind taste testing and cook-offs, and they were really fun to do, and to teach people about pre-soaking beans, which people didn't always know about, and then video testimonials. So these are some of the intervention components that we had of women who said, I didn't think it would taste the same, but it tastes the same, and I'm like you. And then at the motivational level, some of the things that we looked at were really this idea of men making decision-making in the homes that were tangential to and more critically involved in this decision-making about the home cook stoves. And men were saying things in their interviews and focus groups is that we didn't like seeing the forest disappearing, so they actually were taking kind of this long view of their community, and they didn't want deforestation, so they didn't want the wood. And they also didn't want to see their wives being exposed to smoke, so they were pretty motivated when they got engaged. And so we saw them taking more ownership over cooking some of the foods during pregnancy, and then creating images to sort of talk about the long view of avoiding deforestation. So just some of the results is like my last slide here was in this context is that we did find in this sort of short intervention for pregnant women in this pilot study was that wood use decreased over time in the interventions. We hoped that was the hardest part. And we did see increased use of gas, but we did see a waiver once babies were born over time. So there was a lot of adoption early on and then sort of de-adoption. And so this is a sort of ongoing challenge in this space, but this is sort of a step towards moving behavioral interventions into the cook stove space. And this larger trial, the HAPPEN trial, which is across many many countries, this is something where they're expanding upon this behavioral approach, but also trying to figure out can they use those kind of elements that I was showing you about very briefly to understand the fidelity of the intervention implementation. So these are just some really, really brief ways that you can think about using implementation science when you're trying to both augment an existing intervention as well as potentially de-implement something in your work environment. Thank you.
Terrific. Thank you, Margaret. Our next speaker is Adithya Cattamanchi. Adithya is a professor here, associate professor of medicine and a pulmonary and critical care physician at the Zuckerberg San Francisco General. He's an expert on TB and spends a lot of his time doing research related to the delivery of evidence-based care around tuberculosis in low-resource settings. He's also co-director of the Implementation Science Program here at UCSF, and we'll look forward to his comments on some of the work he's done in TB.
All right, thanks, Colin and Jim, for inviting me to sort of present today. So I'm going to talk about some of our work in Uganda that's been focused around trying to figure out how to sort of improve the process of sort of TB diagnosis and treatment. This is a problem that we've been working on for a number of years, starting initially with sort of improving smear microscopy-based diagnosis at peripheral health centers, and then sort of updating over time to sort of focus on what's really been the kind of new player in town, sort of the molecular testing with GeneXpert. So in terms of the global context, I think most of you probably know in this room that TB is now sort of the leading infectious killer sort of worldwide. And one of the big challenges in the worldwide data is that we have about 10 million sort of estimated cases worldwide, but really only 6 to 7 million of these are reported to TB programs annually every year. So there's about 3 to 4 million sort of missing cases, right? And these missing cases reflect a combination of cases that are maybe diagnosed in the private sector and treated but not reported to programs, but also a large fraction of patients who are actually just never diagnosed, right? And so the real sort of response to this has been an interest in sort of scaling up sort of better tools. We've been relying on smear microscopy for more than 100 years, and we all know this test is insensitive, detecting less than half of TB cases. And it also is resource intensive in the sense that it's not expensive to do, but it takes sort of trained lab techs, and it takes sort of patients have to come back over multiple days to submit sputum specimens. And so because of this, there's really been kind of a lot of interest in scaling up sort of better, a more accurate and sort of easier test to do. In particular, there's a test called GeneXpert, which Cephii had sort of developed now about almost 10 years ago. And this is the first sort of semi-automated molecular test for TB. It can be done in under 2 hours. It's almost twice as sensitive as smear microscopy. And because of concessionary pricing, it's sort of available at a cost that's sort of reasonable for low-income settings. So the bottom line is that the donors and countries have invested lots of money in scaling up this technology. This is based on the studies showing that it's more accurate, but also on sort of cost-effectiveness studies, right, showing that this technology, based on the accuracy estimates from the clinical studies, is highly sort of cost-effective. And so donors have invested lots of money, countries have invested lots of their own money in sort of procuring these devices. And since when it was first introduced in 2010 to, this is just data through 2014, you can see this rapid sort of uptake of GeneXpert devices and cartridges, and it's only continued to exponentially increase over the last 5 years. Uganda has actually been a leader in sort of scaling up this technology on a per capita basis. It's been among the global leaders in terms of the number of cartridges and number of devices procured. There's now more than 500 devices in the country, and almost now 500,000 sort of cartridges have been procured and used. The red dots on the map show sort of health facilities where there's the GeneXpert device, and Uganda has decided to, like many other high-burden countries, has scaled up this technology in sort of a hub-and-spoke model, meaning that the GeneXpert devices are placed in district-level facilities, and they're linked to three to five sort of peripheral sort of microscopy units that send sputum samples to the central site for testing, and then the results are returned back to the health center to inform patient care. So in theory, patients all across the country now have sort of access to GeneXpert testing in addition to sort of smear microscopy at the peripheral units. But I think despite this sort of massive scale up and these massive sort of investments that have been made in this technology, there are some unresolved questions, right? So how well are these referral networks actually functioning? How well do these hub and spoke models actually result in these technologies being delivered to patients? What's the actual quality of care within these expert referral networks? Has the availability of expert testing improved sort of the quality of care that patients are receiving? And are there policy changes or co-interventions that can further enhance the quality of expert implementation? So these are the types of questions that we've been sort of trying to focus around, and there's a project that we've been calling the Xpert sort of Performance Evaluation to facilitate linkage to TB care, or the XPEL TB study. And so the aims here have been really to quantify the gaps in TB diagnosis at health centers that are now linked to these expert testing sites, to identify what the modifiable barriers are using sort of implementation science frameworks to high quality TB diagnosis at the provider level, at the patient level, and at the health system or clinic level, and then to develop and test a theory-informed intervention to improve the quality of TB diagnosis. I'm not going to go into all of the details of the sort of implementation science frameworks, I think as Margaret sort of nicely did, just for sake of time, but I'll try to highlight sort of some of the results that we've had over the last few years. So for aim one, this is really about defining the quality gap, and this is how implementation science often starts, right? So what is the gap, and can you quantify it? And so for this, we relied on the international standards for TB care, which Eric Gooseby and others sort of were involved in developing. And this is a set of guidelines that have now been adopted by almost every TB program worldwide and sort of most professional societies. And in particular, related to diagnosis, there's some sort of simple sort of recommendations that I think are universally accepted. These are first that all patients who have presumed pulmonary TB, so these are patients with signs and symptoms of TB, predominantly having cough for more than 2 weeks, should be referred for sputum-based microbiologic testing. The second is that sputum-based testing should involve the GeneXpert test whenever it's feasible, or at a minimum examination of at least 2 sputum smears. And lastly, patients who are positive on either microscopy or Xpert should initiate treatment rapidly. So these guidelines form sort of a framework on which we can develop sort of quality indicators to assess how a program or clinics are performing. So we kind of assess these sort of these quality indicators at kind of a selection of sort of health centers across Uganda. And what we did was among all of the referral networks that had been, expert referral networks that had been set up across Uganda, we chose sort of a sample that was kind of distributed throughout the country, but reasonably close enough to Kampala that we could sort of easily go and sort of access data. And so the facilities are shown on the map. The yellow stars are the facilities, and the red triangles are the GeneXpert referral sort of testing sites to which they send samples. They were studied, the only real selection criteria was that they had to do enough TB testing that we could gather data. So I think they had to test at least 25 patients a month for TB. So the participants for this study were all adults undergoing TB evaluation at these health centers. And what we did is we extracted patient-level data from the routine TB registers. TB is a notifiable and reportable illness, so the one nice thing is that all the health centers use standardized registers to collect information on who's getting tested for TB, what their test results are, and then who starts treatment and what their treatment outcomes are. So that data was sort of available for us to sort of extract and use. These were sort of the results of some of the initial studies that we did to document the gap, right? So this summarizes data on a little more than 2,500 adults who were undergoing pulmonary TB evaluation over about a 1.5-year period. And the first indicator reflecting the international standards was the proportion referred for sputum-based testing. And about 80% of those who had signs and symptoms of TB were referred for testing. The second indicator was those, if they were referred for testing, did they complete testing? Meaning that did they have either a GeneXpert result that was valid, or did they have at least sort of 2 microscopy results? And a little more than half sort of completed that step. And the third indicator was the proportion who were actually treated and treated rapidly within 14 days if they were smear or Xpert positive. And here about 73% did. But the bottom line is what this means, that if you were a patient with smear or Xpert positive TB, and you were coming into these health centers, you only had about a 1/3 chance on average of being diagnosed and treated, right? So pretty abysmal, right? Despite the large scale up of these new diagnostics and all of these investments, we're still only at about 1/3 of patients being diagnosed and treated on average. In terms of the utilization of Xpert testing, only 17% of patients were referred for Xpert testing overall, including only a third of HIV-positive adults, right? Despite the guidelines saying that everyone with HIV should have this as done as a first-line test. And then only 7% of HIV-negative adults. It almost wasn't being used at all in those who were HIV-negative. Less than 5% of the patients who did undergo Xpert testing were referred for it as a first-line test. So even in patients with HIV, the vast majority of them were first getting microscopy and then sort of being referred for Xpert testing if that was negative. And then less than half of patients who had positive Xpert results were initiating treatment within 14 days. Right? So even if the testing wasn't being done, ultimately what we care about is that these patients are getting linked to care. It doesn't really matter if we have the technology scaled up and the results aren't being used to inform patient care. So I think bottom line, a summary for AIM-1, the quality of TB diagnostic evaluation at these health centers is really suboptimal. Uptake of Xpert testing is poor, and linkage to treatment for Xpert positive patients has really been inadequate. So our next work focused on sort of trying to understand this, this quality gap, and we used a conceptual model called the theory of planned behavior, which essentially focuses around what are the determinants at the sort of individual sort of provider level around their intentions to follow guidelines and then their actual sort of guideline adherence, which is going to sort of result in more case detection and treatment. Because we're working in low resource settings, we also sort of thought it was important to address patient factors, particularly their time and costs, and also health system factors, the physical resources and material resources that are available for facilitating TB workup. I'm going to skip over the data collection. We kind of did some mixed methods work, including interviews, field observation, and surveys to kind of gather data on these factors. And I've summarized the results here according to an implementation science framework called the PROCEED framework. The PROCEED framework highlights 3 categories of factors: predisposing, enabling, and reinforcing factors. And these are types of factors that, if addressed in a multi-component intervention, are thought to sort of increase the likelihood that actual uptake of the intended behavior will occur. And so some of the barriers that you see are listed there. I mean, I think they're not sort of earth-shattering. I mean, time and resource constraints for health workers, particularly related to microscopy, resulting in low self-efficacy. There's also this persistent belief that TB evaluation is not urgent. So if a kid with malaria came in, they would get tested right away. But with TB, it's okay if they ask them to come back the next day or the next week. And so this was a big problem. Enabling factors, patients just didn't return after the initial visit. So it was very clear from both patients and providers that if you couldn't get everything done in one visit, the chance that a patient came back was low. And a lot of this was mediated by sort of the costs and time associated with accessing clinics. There's inconsistent or delayed specimen transport, and so on. And then reinforcing factors, one of the things that was highlighted a lot was really this issue of sort of communication and identifying problems and not being able to sort of fix them because they weren't aware of what they were. So we kind of designed sort of an intervention to sort of target some of these key barriers. And this is through a process of evidence review, consulting with our local stakeholders to assess sort of what's feasible, and then prioritizing which barriers to address, selecting some co-interventions to target them, and then thinking about how they would be delivered in this context. So this is the intervention that we came up with, right? So single sample of fluorescence microscopy. So this was basically a tool where people were just, instead of collecting another specimen, doing sort of 2 smears on the same specimen and analyzing it by sort of a faster technology, LED fluorescence instead of routine microscopy, performance feedback to address the communication factors, and things like daily sputum transport and SMS-based reporting of Xpert results to address the fact that patients may not be sort of coming back right away for another sort of evaluation. I'm going to skip over the details for time, but we kind of looked at we did a single-arm interventional study to pilot this intervention. And what you can see is sort of large improvements sort of across all of these metrics. Right now, 99% of patients are being referred for testing, 99% are completing testing, and 85% are being treated. So that proportion your chance of being diagnosed and treated went from 33% all the way up to 84% with just sort of a fairly simple intervention. And then in terms of Xpert utilization, now almost all smear-negative patients are being referred for Xpert testing, and 3/4 instead of less than half are being started on treatment if they were tested positive. The algorithm sort of worked well. I mean, for the most part, people were doing sort of what we intended them to do. They were examining smears quickly. The one thing that was low was the proportion who were treated on the same day if they were smear positive, and we'll talk about that more in a second. But bottom line is each component of the algorithm was implemented sort of fairly well. So we think this is a sort of feasible strategy. It considerably improves the quality of care, and and the one thing is that sort of rapid linkage to treatment can be further improved. And so the next iteration of this intervention is taking into account newer technology. In particular, Cepheid has developed sort of GeneXpert platforms that can actually be implemented at these lower level facilities. So instead of sort of microscopy and sputum transport, we're replacing that with sort of on-site molecular testing, and we're now in the middle of a sort of cluster randomized trial looking at this package of interventions across the health centers. So in terms of conclusions, I just want to, even if a diagnostic is cost effective based on its accuracy estimates, scaling it up alone is not really going to improve the quality of diagnosis or increase case detection, right? So just having high coverage of these technologies doesn't equal quality. Health system interventions are needed to support effective implementation of new diagnostics and linkage to care. And we think that implementation science frameworks can be useful for identifying what those types of interventions are and how they can be feasibly delivered in these contexts. So last, just to acknowledge sort of the team, particularly on the ground in Uganda, who sort of led most of this work, and our partners at multiple institutions and funders. Thank you.
Great, thank you. Our next speaker is Ruanne Barnabas. Ruanne, welcome to UCSF. Ruanne is Associate Professor in Global Health and Medicine at the University of Washington, where she holds the King Holmes Endowed Professorship in STD and AIDS. She focuses on interventions for HIV and STD treatment and leads a number of different cost-effectiveness evaluations and different topics and trials that I won't go into here in the interest of time. So let's get you set up.
So good morning, everyone. It's a real pleasure to be here. Thank you so much for the invitation to join you today. I'm also suffering a bit of imposter syndrome since I'm not a health economist by training, but I hope that some of the work we've done on evaluating the cost effectiveness of differentiated care and viral load testing will contribute to some of the discussions today. So I'll give a little background about differentiated care and viral load testing for HIV, and then discuss some of the systematic reviews we've done, the results to date, and what the next steps in this work will be. So differentiated service delivery for HIV is a client-centered approach to help us achieve the pathway to the UNAIDS 90-90-90 goals, and that's to test 90% of people living with HIV, link 90% of people identified to treatment, and achieve viral suppression among 90% of those on treatment. And these streamlined services for HIV care through differentiated care have the potential to achieve better outcomes and at lower cost to clients and to the health system. And we need this for people living with HIV because there are an additional at least 10 to 15 million people who we expect will start antiretroviral therapy in the next 20 years or so, and about 10 million people who need to start today. HIV viral load testing is an indication of client and program success. So for the individual, having a suppressed viral load, i.e. no HIV virus detectable in the blood, is an indication that the ART is working. And at program level, if 90% of clients are suppressed, you know that your program is working to deliver antiretroviral therapy to people who need it. But differentiated care is pretty new, and we need evidence on both the effect size, so the effect on health, and also we need evidence on what this is costing. There are several strategies for differentiated care, and you can see here on the slide, for example, you might have a healthcare managed group. So this would be a group of clients who have HIV, and a healthcare worker meets with 20 to 30 clients every month and distributes their medications. Or we also have client-managed groups. And so here, a client will pick up ART for 6 to 8 people and bring them back to the group and give everyone their monthly ART, and people will take turns going to pick up the ART. And when it is their turn to pick up the ART, they see the doctor for their 6 monthly visit. Then there are facility-based models where you can fast-track into the clinic and pick up your antiretroviral therapy. Providing antiretroviral therapy is a significant burden on the health system in some countries. In South Africa, for example, 75% of pharmacists' time is spent refilling antiretroviral therapy. So these models where people can come and pick it up more efficiently, some inside the clinic, and then the last model, out of facility, models where people can pick up ART from supermarkets. So, for example, the equivalent of Safeway, you can go in and pick up your antiretroviral therapy, even though it might not ordinarily have a pharmacy in it. So several studies have reported differentiated service delivery outcomes for retention in care, viral suppression, and mortality. And there are some data available on cost to estimate the budget impact and cost effectiveness. And these can inform the choice of DSD. So you can imagine for the Ministry of Health thinking about which of these strategies to implement, having both the evidence on the impact on health and the evidence on cost can help them think about how to move clients out of the clinic if that's appropriate, or keep them in the clinic with a fast track facility for picking up their ART. So we did 2 systematic reviews, one on cost and cost effectiveness of differentiated service delivery, and the second review on the cost effectiveness of viral load testing. We followed all the guidelines. That's Jim said, that's all I could say. And we identified 19 studies for differentiated service delivery and 18 studies for the cost effectiveness of viral load testing. So I'll just give you a flavor of some of the studies. So arriving this morning in San Francisco and seeing the UCSF sign, the first thought I had was, oh, the SEARCH study. And so appropriately, the first study I'll talk about is the SEARCH study, which tested treatment as prevention in Uganda and Kenya, and then provided costing for a very streamlined delivery of ART. And one of the wonderful things about the SEARCH study is that they really honed in on the most streamlined approach to provide very high quality care and achieve high levels of viral suppression in Uganda and Kenya. And so they estimated that for this nurse-driven, so some task-shifting nurse-driven care for stable clients, what it cost to deliver in the study was $291 per patient year, but they estimated those costs could be further reduced to $163 using the negotiated prices for ART, and then very importantly, a lower cost for viral load testing. The PRU study in Malawi looked at multi-month scripting and found that if you give people more month supply of ART, so you go up from 1 month to 3 month supply, that the cost went from $135 to $121. And so you can see here just a small saving from decreasing the number of visits to the clinic from 12 to 4 per year. So you might not expect that the saving would be that size, that absolute size. Wu and colleagues looked at the cost of community-based ART distribution by Xpert clients through different clinics in Uganda, and the cost varied from $257 to $404. So you can see that these differentiated service delivery costs are really dependent on the local context, including the number of participants. And then Roberts and colleagues similarly estimated that the costs vary depending on the kind of program. In a very nice study in South Africa, working with MSF, Bango and colleagues estimated that the cost per patient year, being in an ART club, so getting this care outside of clinic, was $300 compared to $374 in the standard of care clinic arm. And the client-managed groups, as evaluated in Malawi, cost $122 versus $135 in the standard of care arm. Barton and colleagues estimated that for nurse-led ART initiation, the costs were slightly higher, but in this study they identified that nurses actually provided more care to clients. And Babagamara and colleagues estimated that using pharmacy workers did save $14 per patient per year. I just want to end on just showing just a couple of things. Then there's a very nice case study from South Africa where they looked at adherence clubs, and they estimated that using adherence clubs had a lower visit cost, $1.52 less per visit, and 4 fewer visits per year, and they had better outcomes. So here, this was the no-brainer that we heard about from Elliot this morning. But I want to point out that overall, so here on this forest plot, you can see on the right where DSD was cost saving compared to on the left of the dotted line, DSD was costs were increased, that there's a real heterogeneity in the costs, and it's very much dependent on the context. For our review of viral load testing, 12 out of 18 studies found viral load to be cost effective, but neither of the clinical trials, at one which Jim conducted, found viral load testing to be cost effective. But we found overall that really 3 factors drive cost effectiveness for viral load testing. So lower cost technology, ensuring that viral load results are acted upon, and ensuring that if someone has a detectable viral load, that they change immediately to second line if that is indicated, or they receive the counseling. And some nice modeling work found that even changing to second line therapy 3 months early was cost saving. And then presented at CROI this year, a very nice study from Paul Drain and colleagues showing that point-of-care viral load testing in the clinic compared to sending the viral load test to the lab did improve clinical and retention and care outcomes by 14%. So overall, we found that differentiated service delivery can be cost-saving compared to the standard of care. But with adding these new services, the net savings may be small, and the cost-effectiveness results are really context-dependent. And for viral load testing, you need clinical action to realize the health benefits. So very much like Adithya was saying, the implementation of the intervention has to be in keeping with the modeling, as modeled, to see those model results. And we do expect that several studies will report costing data in the next year or so. So in next steps, we will look at the comparability between these cost estimates and compare client characteristics around models, and use mathematical modeling to assess the threshold coverage for DSD to be cost-saving overall. And I want to thank all my colleagues who did much of this work and who read all the articles, extracted the data, and then Carol Elvin, who provides a lot of expertise for us at UW on health economics. Thanks very much.
Great. And our last speaker is Elvin Geng. Elvin is Associate Professor of Medicine here in the Division of HIV/AIDS, and is an expert on this stuff, and has led a number of fascinating topics around follow-up to care and other issues related to HIV treatment, diagnosis in low-resource settings. Welcome.
Thanks. Good morning. Thank you, Jim and Steph, for the opportunity to talk to you guys this morning, and looking forward to discussion around this. So this title is called "What's on the Dinner Menu? Optimizing Differentiated Service Delivery Models." So I have to admit that the idea of sort of optimization and optimizing was something that was brought first and foremost into my attention when Jim called to ask if I'd be willing to talk about something related to optimization. And I'm in a room full of economists who think a lot about this kind of stuff. So I will put forth a few preliminary thoughts and see if this resonates with people. But here's some background ideas about optimization before we get into the differentiated service delivery model. So I guess in the context of the HIV public health response, optimization probably means providing the most effective and lowest cost distribution of services for HIV treatment. If the nature and severity of barriers to treatment is very variable, then no single intervention type or intensity will be optimally efficient or effective, right? So any one intervention will not be needed by all, therefore squandering resources on those who don't benefit, nor help all in need, thereby failing those who could benefit. So the solution has to be something around targeting the distribution of the things that we have in our toolbox to those who will respond, for whom the intervention is a necessary cause of engagement in treatment. So what's a strategy to find this match? And I think that one of the interesting things about this topic is that, in the HIV world, as Ruanne mentioned, there's this enormous effort to scale up differentiated service delivery models. And this is, I think, a great case study in thinking about how we should think about optimization. So this, I'll fly through the background, both because lunch is imminent and because this won't be lost on anyone here. But over the course of the 10 years between 2005 and 2015, there was an enormous scale-up of antiretroviral therapy around the world, from essentially sort of zero coverage in many places to 30, 40, 50, 60, 70% of the population in various places. But during this time, a lot of things changed. One of the things that changed was that the sort of average or median patient became very different, right? And so in 2005, you had a relatively low CD4 count at initiation. Most people had been on treatment for a relatively short period of time because they were just all starting treatment. And then their current CD4 was not very high because they'd only been on treatment for a short time. By 2015, the situation was very different. Most people came to care healthy. They started treatment healthy, and the people who were on treatment had been on treatment for a long time, therefore being much healthier. And so the patient population was different. And during this time, also, the systems that were created to treat HIV became highly stretched. So lots of images of crowded facilities here. This is a particularly nice study from Uganda. I'll just call your attention to the last column here. This is the amount of time that you spend at the clinic when you visit the clinic. And irrespective of your client category, non-art, under-prep for art, early art, stable art, you spend about the same amount of time at the clinic. And you spend a lot of time there, 200 minutes, 300 minutes. This is basically your whole day. And in this context, around sort of the late, sort of probably almost 7 or 8 years ago now, there were some health service delivery innovations that came into focus. And I think this all started with the self-forming patient groups in Mozambique, which later became called CAGs, or community adherence groups. And in this model, instead of going to clinic every month to get your medications, which was the standard, you formed a group with your neighbors or your friends, a group of 6, and you would rotate. So every month somebody would go to clinic. They would pick up drugs for the other people, and they would get a clinic checkup themselves, including a monitoring CD4 count. And this created lots of efficiencies because you reduce your opportunity costs of going to clinic, you create some social cohesion around going to clinic, and enhances sort of adherence to that visit. And since that time, this strategy of differentiating service delivery models has really sort of taken off and has been kind of crystallized and promoted by WHO and by many stakeholders. But some of these things, as Ruanne mentioned, fast track. You show up, your meds are there, you pick them up, you don't have a full clinic visit. Community adherence groups, we talked about. Urban adherence groups are a different variant where the group is larger. You meet as a group once a month to pick up prepackaged medications, or once every 3 months, et cetera. And as this effort, I don't think that there is currently an estimate of how many people on treatment in low and middle income countries, or in Africa specifically, are in a differentiated service delivery model for treatment. But my guess is that it's fairly penetrant, right? So that like perhaps, I'm going to take a guess, and somebody could, I could be wrong here by many orders of magnitude, but something like maybe half to maybe 70% of patients are now in some type of model like this. So the research questions that have emerged in the literature, as we take a survey on them, and which was sort of prompted, people are asking questions like, does DSD work? What's the comparative effectiveness of DSD? But there is relatively little empiric data about optimization, or how do you combine these together. Let me just give you an example. Here's something that was presented at CROI a year or so ago. Comparative effectiveness of adherence groups, larger adherence clubs, but randomized to, is it at the facility or in the community? So we're going to randomize you, if you participate, to joining one of these groups, and you can do it in a group in a facility or in the community. They followed them for 24 months. They found sort of not great retention in either, but surprisingly, unlike what they hypothesized, the clinic-based one did better. But instead of interrogating that particular sort of finding, I think the conversation here around optimization asks us to ask, what are the kinds of things that we could learn from from a comparative effectiveness study, and is that where we want to invest our time and energy? So let me try to bring in this concept of mosaic effectiveness, and this is a term that Dave Glidden and some other people have started to use around what you really want to know about the public health impact of an innovation, right? So if you introduce red to blue, the classic example is sort of comparative effectiveness, so you get randomized to one or the other. So it could be that the situation is like case one, right? Red is not as good as blue in a comparative effectiveness comparison, but it is going to contribute to overall public health impact because it works on the people for whom the blue doesn't work. And it could be, but it could also look like this, right? Like the red is nested entirely within the blue, so its comparative effectiveness is worse, and it has no contribution. So what we really want to know, therefore, is to what extent these innovations contribute to the overall sort of square as you go along. And so I would say that if you were going to, the standard for DSD, empiric DSD research should be stuff to get at mosaic effectiveness. Again, here you can extend this to like sort of many different interventions. DSD models with less contribution in green here, more contribution yellow here, same comparative effectiveness. Okay, but the question is, how do we order from this menu? If we know that what we want is this kind of a menu, how are we going to order from it? And then how are we going to know what the distribution of interventions that matches the needs of the population are? And I would say that that's, I don't know the answer to that question, but here are a few kind of like thoughts about it. So number one, trials. Do you want to do a trial about this? Well, especially a trial to find what's called an optimal dynamics regime. I mean, there are techniques to try to get at this, but it's not easy, smarts and stuff like that, because there are just too many combinations, and you're not going to do a trial, especially at the cluster level, for like every combination. My time is diminishing rapidly. Models, too many assumptions. Qualitative interviews, no quantification. One technique, however, that could potentially play a role here, I think, is choice experiments. And, talking to economists, I don't need to talk about what those are, but as a premise, sort of, this is my caricature of the economist view of the world. We're trying to be happy, live in a world of constraints, make trade-offs, decisions depend on your preferences, and these are increasingly used in global health. I first was exposed to this by reading Margaret Cruck's article about this in AJPH a number of years ago. So can we apply choice experiments to understand the optimal distribution of DSD models? Okay, so we've done a couple of them, and I just want to tell you about the results and use that to inform kind of like our thinking about optimization. Okay, so this was done in Kenya in the FACES program. The FACES evaluation unit can take credit for this, and a student from the Global Health Master's program. So the models were sort of decomposed in this choice experiment to their important attributes. And their attributes were varied, and patients were approached and asked to choose between two clinics that were composed of different response levels to each of these attributes. And by choosing these attributes in a repeated fashion, it tells us or uncovers the preferences of the patients, and it quantifies the preferences, and you can use those quantifications to essentially capture trade-offs, what somebody would be willing to trade to get something else that they prefer. This is the type of attributes that we had: location of refills, frequency of receiving refills, adherence support, the type of adherence support provided, the person's providing the support, and these are the response categories. Here's an initial analysis. I won't belabor the details of the analysis, but this sort of shows the relative importance of these different attributes. They're ranked in order of importance to this population of patients, which was approximately, over 150 patients. So location of clinic review, very important. Location of refills, very important. Frequency refills, very important, et cetera. And then these other things are important, but less so. So what were the preferences here? Okay, number one, location, location, location. So up is happy, down is unhappy. So it turns out that both for the location of ART refills and the location of clinical reviews, that patients wanted to get it at the facility. It made them happier to get it at the facility, and the community meeting point and the home both made people unhappy. Timing is everything. So people want to go to the facility, but they don't want to go very frequently. Every month, very unhappy. Every 3 months, a little happier. Every 6 months, very happy. Who's who? So unlike the general beliefs about sort of decentralizing care into the communities, there is still this belief that patients want to be seen essentially in an individualized way. So no support, very bad for adherence. Individual support, very good. And then group support, people are sort of happy with it, but not that happy. Same thing with person providing sort of an ART. People don't want to receive their ART from a community member or a lay healthcare worker. They want to get it from, sorry, the colors are not totally matching up here, but you can see that people want to get their ART from somebody who they think is good at giving ART and giving it in the right doses, and that's the pharmacist. So we also did a choice experiment in Zambia that was similar, had similar attributes and similar response categories. And I bring it up here not because the results are very different. They actually reflected remarkably the same interest or preference for getting treatment at the facility in a totally different setting and context, but also because you can analyze using latent class analyses the responses to find whether or not there are preference groups, there are groups of preferences that hang together, therefore defining sort of like the sort of different phenotypes of sort of preference groups. So in this particular case, in Zambia, even though overall we found that there were 85% of people found sort of longer frequency for visits very important. They strongly preferred the clinic, and they liked like having a buddy. This is sort of the 85%. There was a group of 15% of patients that were different. These patients wanted 3 months visits, but their preference for it was much less strong than the other group. They preferred treatment in the community, and they were indifferent to having a buddy. So to me, like we thought that this 15% were a group of people that that prioritized sort of location in the community, whereas the 85%, getting refills or clinical reviews at the facility sort of drove all the other decision making. Let me bring one figure into this before my final figure. This is a study that was done in Malawi looking at uptake and of differentiated service delivery models. So MMS is multi-month scripting. That's just a model where you just give people a lot of drugs. FTRs is the fast track where you just show up and you have everything's prepackaged. And then the CAGs are the ones where you form a group of 6 with your community members. So the first thing to note here is that the 100% are the people who are eligible for this model. And this was done under sort of health system settings. The first thing to note is that the vast majority of people who were eligible for CAGs were never in a CAG. So from a health systems perspective, this sort of reveals that it's actually, there are differences in the implementability of these interventions. So when you combine that with the landscape of preferences among patients, I think that what we would want to, my takeaway from this is that the optimal distribution is something closer to a main course approach than a tapas approach. In other words, sorry, I wasn't optimally clear about this, but you know, of the menu sort of multi-month scripting, community ART groups, adherence clubs, fast track models, the one that most fits what people want is the one that is most implementable, which is you get your treatment at the facility, you go to the facility for your care, but you just don't go that often. And you're seen by the highest cadre that you can be seen by when you do go. And this is, I think, contrary to the assumptions that are driving a lot of the scale up of differentiated service delivery. So I would say that the optimal approach is a main course approach where you put people in multi-month scripting, as many as you can and who want it, and then you offer the other ones as like dessert. So multi-month scripting is breakfast, lunch, and dinner, and then the other ones are dessert. I think where we're headed right now in the world is this approach where sort of all are being promoted at the same time, and you're ending up with like a tapas approach, which, like my provisional argument here, is that that's not the optimal approach if you take preferences into consideration. Okay, so as wrap up, DSD models continue to scale up. The right mix is an important question and hard to answer with the traditional toolbox. Choice experiments may play a role here. And what people want in this type of intervention is likely related to how effective it'll be. So because use is critical, and therefore sort of choice experiments have an important role in defining the optimal menu and ordering from that menu. So let me just wrap up here. I think I've exceeded my time, but want to thank my colleagues working with the FACES program in Kenya and the CIDERS program in Zambia, with whom I've had the pleasure to collaborate. Thanks.
Super. With that, I'd like to invite the panelists up to the front here. And what we'll do is I'll pose a couple of questions to get us started, but we do want to open it up to the audience for Q&A as well. My background is not in medicine, it's in business. And I couldn't help but notice as you were going through the presentations that the choice experiments looks a lot like the sort of things I would have studied in a market research class. And the combi model sounds a lot like a marketing class. And the TB interventions and direct service delivery interventions are the kinds of things you would see in an operations class or a service management class. Is implementation science just management?
The claims that we make about science all depend on the conversations that we're a part of and that we come from. And so while many of this stuff I feel like resonates with ideas in other fields, and implementation science is explicitly interdisciplinary, right? Like the idea is that it draws from different disciplinary traditions. I think that there's no, that is true. There are these resemblances. And I think at this point in the field, implementation science is putting its own distinct imprintur on lots of these problems. So I don't think it's like sort of an either or thing, but it's perhaps a part of an evolution in the conversation in health. But my colleagues may have different views on this or similar.
Yeah, I would just go ahead and say I really agree with that, but also sort of think that if you think of any sort of scientific revolution or changes in scientific thinking historically, there's always sort of this tension in the early stages of new skills and new components being developed, where there's like, wait, does that fit into our structures that we already have? And then there's sort of a period of time where recognition of new components is sort of part of the establishment, and then there's reactions to that. And so there's sort of like a long view of how history of science really sort of turns on itself, but then integrates itself. And I feel like this is sort of in that integration phase. And I think that's a really interesting place to be, but it's part of that interdisciplinary nature of it, drawing from all these different disciplines, that language and conversation has to be very diverse over time. So I think that's an interesting place to be.
Anyone else?
Yeah, I mean, I'll just add, I guess, why does it matter? I think the bottom line is that these tools need to be used more in health and in our health planning and our health programming. And whether you want to, if you're from a business and management background and you have some of these skills to apply, great, right? If you're from a health background or a medicine background and you've learned it through other ways and you want to call it implementation science, great, right? But I think the bottom line is that, our approach to thinking about these problems and our approach to solving them needs to be broader than the traditional sort of biomedical lens that we've had in medicine.
I'll agree with my colleagues and add that my colleagues in psychology think that implementation science is really behavioral science. So I think it depends on the lens with which you look at the subject. Right. Yeah.
Okay, thank you for that. Second question, then we'll open it up to people from the audience. Again, struck by the massive range of the variation in performance, whether it be the cost effectiveness of different DSD models, 33% success rate to start with tuberculosis test and treat in places which actually have GeneXpert, an enormous range. There was a discussion earlier this morning, a really interesting one about the role of cost effectiveness analysis and using that as the basis for prioritizing. health interventions and investments. But that presumes a certain level of implementation success, and what we're seeing is actually a quite broader range than a point estimate. Are we better off thinking about this differently? Should we be prioritizing the interventions we can implement best, even if they're not the right ones from a cost-effectiveness analysis, instead of interventions that will only, where there's greater uncertainty about the ability to successfully implement it?
I can start. I think when you say what are the right ones from a cost-effectiveness analysis, if those cost-effectiveness analyses are based on optimal implementation, but that's not realistic, then I'd argue that maybe that's not the right one. And so I think that's part of the challenge for cost-effectiveness analyses is how do you take account the impact of differentiated sort of delivery and differentiated ability to actually implement and scale up various types of interventions. And I would argue that we should be prioritizing interventions that are easier to implement, even if at optimal implementation of two things, one is better, but it's much more difficult to implement. You're unlikely to achieve that sort of optimal role. And I think it would be good to have sort of cost-effectiveness modeling sort of take into account these types of data on the extent to which a particular type of intervention is being implemented or what is needed in addition to the intervention itself or the technology itself to enable sort of uptake. So what implementation supports are needed and what do they cost, right? Or if you do have these different menu options for various types of sort of implementation supports, how are they sort of cost effective given sort of patients' sort of preferences and their ability to achieve the outcomes desired?
Mm-hmm.
So I can add that in our work of doing the reviews, one of the frustrating things and maybe also one of the opportunities is how long it takes for the data on the effect size, the impact on health, and the costs to be available so that we could so that these data can contribute meaningfully to choices of differentiated service delivery strategies. And so there's an opportunity here for us to think differently about when we are piloting or trying new strategies, that we in real time collect some of the data or even take advantage of routinely collected data through PEPFAR-funded sites and others to come up with a kind of minimum data set that can help us evaluate the health impact in real time, because everyone's looking at viral suppression as the health impact, and there are data available on costs. So if we could assess that earlier on and learn from programs that are very successful, then we can share earlier on some of the successful strategies and inform decisions for differentiated service delivery.
Mm-hmm.
I think that something that too is important to think through is like what are the partnerships that can maybe offset costs in other sectors. So thinking of some of the things like in the wood stove work, there's a lot of public-private partnerships about bringing petroleum gas stoves into community settings. It's not only in the health sector that kind of cost is absorbed, and so like what are the ways of thinking more at that kind of population health impact about how to maybe have costs be offset in different sectors, so it's not only one sector that's sort of putting in all the cost inputs.
Thank you. Elvin, do you want to?
I think that the cost effectiveness work in implementation science is obviously challenging for many reasons. Number one is effectiveness is often highly contextual, but I think that I'm not in the field of cost effectiveness, so I don't know if there's data that's being collected about the sort of costs across the distribution as you go from like sort of 0 to 100, right? Because the cost of implementing whatever may be easy between 0 and 50, but certainly when you get to sort of, if you want to test 100% of people between 90 and 100, you're going to spend 20 times as much on one test as you are in another. So I guess like what I would want to learn from like sort of costing work is whether or not that calibration is brought into sort of cost effectiveness analysis.
Yeah, and I think that'll be, an interesting discussion, and there may be people in the audience that have a point of view on that. My sense is that we spend a lot of time and money getting a very precise and accurate measure of efficacy. We do well, not as well, but we spend some money and effort on getting a cost estimate that's a point estimate, and we do less well in thinking rigorously about either performance differences in different contexts, how that will vary, and also how the cost will change as you go from the first the marginal cost as opposed to the average cost or the median cost gets a little bit less attention still. We do want to open this up to comments and questions from the audience.
Yeah, I sort of see this discrepancy between some of what was presented, and I'm not sure if I'm misunderstanding, but my understanding was that these sort of community-based approaches where you have one individual every month going and procuring ART for different members of the community is very effective. But in one of the charts where you were showing the results of those discrete choice experiments, it seemed like it wasn't favorable, and that people didn't like receiving the ART from their peers. They preferred to receive it from a healthcare provider. So am I misunderstanding this, or is there an explanation for that discrepancy?
Well, you're not. I don't think you're misunderstanding it. I mean, I think that the effectiveness on a population level of those community adherence groups is unestablished. So the enthusiasm for these models initially came out of a uncontrolled single-arm observational study, and many of these models got a lot of policy attention behind them without the kind of like rigorous study that would truly establish their population level effectiveness. And my presentation was probably unclear in setting that up as sort of the point of departure, that there is policy support for these things, but we don't really know about, number one, their sort of effectiveness in the real world, and number two, how much they contribute to the effectiveness of an optimal menu of such models. So the choice experiments suggested that those types of models where you get your treatment in the community and you get your treatment from peers may not be the ones that are actually favored by patients if you were to actually study it and ask them about their preferences directly. So yeah, thanks for that question.
Hi, Brittany Hagedorn from the Institute for Disease Modeling, and my background is also business, so that's my bias. But I wonder, when we think about like a vaccine or a drug, we can say it has certain probability of a certain outcome happening. We have our efficacy data, and we think that sort of human bodies work more or less the same around the world, and we can sort of make some generalizations from that. But implementation is very different. It's very localized. It's very culture dependent. Social factors. How do you think about generalizing from these studies? Are they generalizable, or do we sort of have to do this in every place for every intervention and test all these different models? How can we sort of think about that transfer to sort of scaling up the conclusions that we draw or don't draw?
Sure. I think that's a great question. Just to make the point about the vaccine, though, I mean, a vaccine is based on sort of biology, and if there are not sort of presumed biological differences, it may be efficacious across populations. But as we're seeing with the measles outbreak here, I mean, we have an effective vaccine, but that doesn't mean that it's actually going to be used and adopted, right? And so I think that's the problem that we're trying to solve. When you have an intervention that's proven to be effective, I mean, whether it's GeneXpert for diagnosing TB, it works, right? I mean, there's really, it's clear, it doesn't matter, sort of, it's better than microscopy regardless of who you test. But the question is sort of how can you deliver it in a way that sort of achieves sort of uptake. And I think the goal with implementation science is to sort of recognize that there are contextual differences and to understand what those are, and then to think about the types of implementation supports that might be necessary depending on the contextual sort of differences that are there. So if you're in a particular setting, it's important to understand not just whether there was uptake, but why there was uptake or not. And then you can sort of, if you actually sort of study that carefully, you can describe that. And in another context that's trying to deliver this, are the similar types of sort of barriers present? And if they are, then maybe some of the same implementation supports that were useful here would also work there, right? Whereas if the underlying reasons for why there was uptake are completely different, right, then maybe you need sort of different types of supports. And so I think part of the goal with implementation science is to focus not just on whether something works, but why it works or doesn't work, and then use that information to understand if it might work in another context or how it should be adapted to that other context. I hope that's sort of...
Yeah. And I just say, I think, a lot of the hope is that there'll be some core ingredients that are identified in certain sets of interventions and certain sets of settings. And so the idea that you might, do the assessment to see if there's local variability doesn't mean that you go off and invent a new intervention in that local setting, but that you're gleaning some knowledge that has been generalized from other interventions that have some similar attributes, and that there's a common language about describing those attributes as both at the barrier level and at the intervention success, like core ingredient level. So I think that's the hope. That's not necessarily the promise.
Yeah, just to maybe echo that, I mean, I think maybe one way to think about it is that findings aren't always generalizable, but mechanisms can be. And I think that implementation science asks us to ask different kinds of questions and frame our generalizability issues in different ways. The other thing is that I think generalizability is a continuous variable. So we're never going to get to E equals MC squared in implementation science, but there is, as Adithya was saying, sort of generalizability that's conditional or contextual to many sort of similar or otherwise like related settings.
And maybe I can add that task shifting is an example of an implementation science intervention that has been successfully replicated in several situations.
Great, thank you. Carol?
Yeah. Elvin, thanks for your the optimization and looking at it from a preference perspective in the discrete choice. And I'm trying to think about, typically we hear about optimization at not the intervention level, but you have choices. You could do differentiated care, you can do facility-based care. There's a bunch of choices that governments are trying to, program components within HIV, and they're often driven by the donor. And this gets to the point that there's an optimization model up there that's often informing governments how they can efficiently allocate, their resources based on optimization. And I know this. So my question is there a way to kind of reconcile preference, optimization that emerges out of patient preferences versus donor preferences or government preferences? Or have you thought about that?
Yeah, well, another good question that I definitely don't have the answer to, but Carol Weiss, he wrote in the sort of 70s and 80s about something that's similar. She has an article which says that a lot of times in science, when you're trying to inform policy, we pretend that we do science and then we serve it up to this policy god that is like rational and like takes up the information and like uses it in the optimal way, whereas in reality like the policy environment is this contested environment with like lots of stakeholders and different actors with different incentives, and she says that maybe this kind of science can sort of serve as enlightenment, right? So you put it into this environment and hopefully the different actors in it make use of it in some valuable way, and at the end of the day you get to a better decision than you would have otherwise. One of the co-authors on that choice experiment in Zambia is the CEO of the non-governmental organization that supports the Zambian government doing care and treatment for 200,000 or more people in Zambia. And we were talking about the results, and I was like, oh, there's so much heterogeneity. We need to offer everything. Like different patients want different things. And she's like, forget that. We're doing these two things, and that's it. Because like at the end of the day, like when you're implementing, you can't accommodate all of those things. But it's a piece of data in the conversation, and yeah.
Yes, I was struck by the data from a couple of the presenters, Dr. Geng and Dr. Handley particularly, about the fall off in actual use of and involvement in treatment and actual use of stoves over time. Should we be concentrating rather than, uptake is important, but should we really be prioritizing the mechanisms and the implementation priorities of those where people will actually use these beneficial interventions over a longer period of time?
I'll just say that I think one of the really interesting areas of research is really looking at those early and sustained adopters and trying to figure out like are there elements of those intervention adoption processes that can be better understood that could potentially be more generalizable. But I think so much work is on trying to just get adoption levels higher that there's not as much research maybe on that sustainment phase, and I think it's really critical. It's a good point.
I don't know if this is on point or not, but I think sustainability often has to, from a health systems perspective, has to do with the fit with the existing health system in one view, right? And so, like for the case of DSD or differentiated service delivery models, like given that the health system is what it is today, which ones of these models are most compatible with like, you know, minimizing the amount of sort of process and other infrastructural changes that would have to go into it to adopt it and then to sustain it. And I think my opinions about that,
Steph?
One of the things I feel guilty about, participating in the process over many years of getting ministries to focus on using cost effectiveness to optimize their intervention mix, is that that was in the context of the big problem not being the wrong interventions were being done, but the big problem was massive management failure in terms of delivering interventions. And you guys have just illustrated that with the perfect 33% example. So my question is, I think this idea of precision public health, the right things for the right people at the right time, is fabulous intellectually. But is it potentially yet another distraction, getting the smartest people in the ministry to worry about the precision of the mix, rather than addressing the blatant, massive failures that we have in management effectiveness?
You are dealing with systems that are grossly underfunded. And where is the rate limiting factors that you're manipulating that really are, I mean, are you unable to discern the actual impact of these issues because it is so underfunded? And I've struggled with that all the time. Is that what are we actually looking at?
Oh, look, it's lunchtime. No, sorry. We could take a quick shot at that.
So, I mean, I think that's a great question. I mean, I guess one thing that I sort of say is that implementation science plays a supporting role in the overall sort of quality and performance of implementation, right? It's like the icing on the cake, perhaps, but the cake itself are often things that are sort of, you know, like you said, these massive sort of like the stuff that's touched on in the winner takes all like kind of perspective where under governance, infrastructure, funding, and these are often things that happen or don't happen that turn on very individual decisions that happen to be the right person with the right minister at the right time, and who allocate like a large amount of money to something. So I'm not sure that those underlying things are always amenable to the implementation sort of science part of it. Yeah.
I mean, the other thing I would add, I mean, I think that, you know, part of this is recognizing that it's not like no money is being spent, right? I mean, whether it's GeneXpert or procuring ART, I mean, things are being bought and money is being spent. And the metrics for spending more money are achieving higher coverage and buying more of these technologies and these devices, right? And there's less attention paid to the management issues and to the implementation supports that are needed. And so I think part of this conversation is sort of saying how, you know, if you're going to sort of, you know, procure, 100 GeneXpert devices, what's your plan for managing them and using them and implementing them? If you're going to sort of implement sort of a new ART program or open a new clinic, like how are you going to, what delivery models are you going to choose and how are those going to be funded and supported? And I don't think donors have thought enough about that, and neither have sort of countries in terms of how they use their own sort of budgets. And so I hope that this sort of types of work that have been shown here and others are doing really highlight that we can't just focus on, you know, achieving sort of the metrics of how many devices did you buy or, you know, how many doses of ART did you deliver, that there needs to be more thought about sort of the management and the supports that are needed to roll out these interventions. And that has to be part of the funding that happens, right? And it's often not right now, whether it's UNITAID or whether it's World Bank. I mean, it's really just about rolling out services rather than sort of thinking about how to deliver those services.
And I'll just add that I think that, you know, in the scientific space that we do have more obligation when we do see success to really sort of go back and explain like what were the contributions to that. I think a lot of times that there's some success seen and then people just want to run with that and blow it up and make it bigger. And there isn't really that sort of process of going back and maybe having put in implementation processes into those evaluations of what success is. People say, oh, these are the outcomes we value. Let's just expand this and scale it up. And I think that work is something that the science can contribute to. And I think that's maybe an obligation we should all share.
Maybe I'll say one last thing, but I think one of the problems with how knowledge generation is related to policy is that things that are sufficient, that can add that last piece of the pie to a sufficient cause, to a health outcome, get a lot of attention. But things that are always necessary but never sufficient never receive adequate attention. And those things are like the underlying management issues. They're hard to study, they're hard to demonstrate the effects of, but they're always necessary, and it's a dilemma.
Parna? Do you have the, oh yeah, back. Thank you.
Hi, Aparna Kolipara, UCSF. Thanks everyone for the presentations. I just wanted to make one comment in terms of this issue around effectiveness. We put money into the inputs, buying GeneXpert machines, for example. And one critical aspect of this is creating the right incentives. And one part of UHC and achieving UHC is the shift from input-based budgeting to output or outcome-based budgeting. And getting managers and clinicians to start prioritizing the output and the outcomes of the patients that they're providing the services for. So just would like to get your perspective on bringing the UHC methodology and thinking around shifting the incentive structures for managers and clinicians and people on the ground.
I mean, I don't know a lot about that mechanism, but what I'll say is that, I mean, I think as Colin sort of started in the beginning, I mean, I think you can shift to an outputs-based model, but if you don't understand the activities needed to achieve those outputs, you know, that might be sort of difficult to achieve. And I think maybe where implementation science and management science and psychology and these disciplines can contribute is sort of trying to understand what are the activities needed in a given context to achieve those outputs. But overall, yes, I mean, I think that we can't just focus on funding inputs. We need to sort of focus on understanding what the activities are needed to achieve the outputs and starting to fund those activities as well, even if they're not as sexy as sort of buying more GeneXpert machines and such.
Go ahead.
I was thinking about the question, I was thinking about, you know, what would really help people focus on the output sooner, and certainly if it was tied to the funding, that would be something that would help people focus on the outputs, and thinking about doing it in real time as well could help identify problems earlier on and also areas for improvement. But also we should take up the challenge of thinking about what innovations can we do to improve management, and to continue to expand the interdisciplinary nature of implementation science. So thinking about are there things that we have tried and should maybe try again in terms of improving management and having a focus on that.
Dean, for I think the last question, and then Jim.
Just want to recall Jim's very opening sentence, I think, that the world has had fantastic success in the last half century in reducing mortality. Rates of halving times of mortality on the order of 20 to 30 to 40 years. Just spectacular. A lot of that happened before there was implementation science. We've heard a lot about problems this morning and how bad things are. But what seems to me, and I appreciate reactions on this, the overwhelming characteristic of the global health sector, and it's the health people that have done it. It's not economic growth as far as I can see. It's not improvement in education. They contribute a bit. But it's the health community that has transformed the health profile of the world. So they're doing something right. And why are we seeing so much difficulty? I mean, I'm not saying they're inconsistent, but it puzzles me.
I think Elvin was sort of hinting at this earlier, but, you know, when things are really bad, it's easy to go from really bad to pretty good. But going from pretty good to really good and excellent, that's where I think things get challenging. And so, you know, I'd argue that, you know, so far we've sort of reduced that mortality by addressing sort of the things that simply can be addressed. And now if we really want to sort of take that to a next level, that's where I think we're going to have to think harder about what the solutions and problems are. And that's maybe where sort of implementation science and some of the other things that we're talking about comes in. And so, it gets back to that same issue of how do you achieve that last mile, that last sort of 10% or 20%, and it's really sort of more than that. I don't know what others think, but I mean, maybe that's part of the way to sort of think about it is sort of, yes, we've done, not to sort of not pat ourselves on the back, but what else do we need to get to where we want to go, while recognizing that we've achieved a lot.
Yeah, I would just maybe add that, we do have a lot of, as we've gotten better with certain things, there's populations that don't retain any of those benefits. And so I feel like, a lot of the problems that people are trying to address with implementation science, it's not that they're at the margins, that they're at populations that maybe haven't had the benefits of all of the components of interventions that have been adopted. And there's a lot of reasons for that, and that requires kind of the context evaluation and the local specification of intervention components. And so those problems end up seeming like they're the enormity, because they're very enormous in the context that they occur, but it's not necessarily the true public health impact of those interventions taken at the population level. So I think both of those things need implementation science, but I think a lot of people are in the space of trying to look at the disparities and trying to use implementation science to really address things that might have multiple components of barriers.
Yeah, I just want to comment that I thought it was remarkable to that sort of question about how to apportion the credit for that to sort of education, economic development, and health is sort of, it's interesting. I'm to some extent surprised, but also happy to hear that you think that it's like something to do with it. But I think the time is right. The time is ripe for implementation science, because I think that some certainly that for the technology to achieve like a 0 to 50 effect is I think maybe what the base investments in health have done, or 50 or 70%, and I think the remaining gap is probably more contextual than it's ever been, and incremental progress is probably harder than it's been before. But
Great, Jim.
So I'm going to ask a meta question. I of course am a huge fan of the role of implementation science, which is, yes, kind of management. What's the right amount of effort? What's the right amount of money as a percent of our total global health spending? How much of that budget should go into implementation science? And for Colin, how much of a company's budget goes into analogous types of management? Is it 1%, 2%, 5%, 10%? What is it?
More. That's all I'll say. Not less.
You're asking the optimization question, Jim. The whole point is it's getting better improvement. It's not about optimization. It's
what's a rough benchmark in the private sector? Rough benchmark.
Well, it depends how you count, right? So I think if selling general and administrative in a typical company might be 20% of sales. Now that's not all management. That doesn't include operations or cost of goods sold. So if you factor in kind of the production management, that would be on top of it. But that's not unusual.
How about a company that's trying to get out into the into the community and deliver service in an analogous way to what we're trying to do in global health? Let's say a food service company like a food chain. How much are they spending on developing and monitoring systems to accomplish their goal of delivering delicious, safe food?
Food truck questions.
Food chain, McDonald's.
Chain,
it's the McDonald's question.
More. No, I think it's very easy to, because so much of this is funder driven, and funders don't like to pay for overhead. And this is, in a sense, overhead. This is what gets called overhead. I'm overhead. I get it. It's what nobody likes that, but it's that's a big part of the challenge.
It would seem to me that if we could quantify that, then that more could be translated into better asks of funders.
I mean, to some extent, it also depends on like sort of which funder, right? I think in the HIV world, if people who pay attention to how NIAID spends its money, I think would very much agree with the idea that it's more, right? Because the scientific community as a whole is still invested in the grand slam home run. 3 quick
business matters to take care of. First of all, very important, that guy who came down repeatedly to make sure that our PowerPoint was showing and who's otherwise standing in the back of the room videotaping this for posterity is Jay Sullivan of IHPS. Please give him a big round of applause for his great work.